congratulations on putting this wonderful conference together and getting such a great turnout. So I hope what I have to say will be of interest to people. Bear with me here. Oops, sorry, a little bit. There we go. Okay, good. So, there we go. So for the next 25 minutes, I'll be talking about improving hearing and in some cases also vision to prevent dementia. What is the evidence? Generally I talk about hearing and vision together, but there's some interesting evidence that's come out in hearing, and there seems to be a real push to try to understand this area a little bit better. So most of my remarks will be focusing on hearing. So a lot of this work has come out from the SenseCog program, which I've been leading for the past 5 years. And this is a European Union commissioned program involving a number of investigators over several countries with various work packages looking at different questions surrounding the links between hearing, vision, and dementia. So why is this important? I think everybody here will be very aware that sensory cognitive health is becoming increasingly important because of the significant increase in coming decades due to ages. And over 66% of adults by the age of 70 have bilateral hearing loss, and a significant proportion have vision loss, and of course cognitive impairment as well. So essentially what we see is this coming together of a hearing, vision, and cognitive impairment. But the historical links of hearing impairment and dementia go back already a long way, even though this is now a very exciting time in the field and there's lots of activity. As you can see here, back in 1968, there was some very interesting work looking at experimental conditions mimicking hearing loss, which showed there was decreased word recall performance compared to normal hearing. There was a classic study in 1989 showing that there was a higher odds of dementia in people with hearing impairment compared to people with normal hearing. So there's been a number of hints and quite growing evidence along the way looking at the relationship between hearing and also vision impairment and dementia. Of course, on a daily level in the clinic and in practical experience, we see this, how hearing impairment impacts on our ability to do even the most basic cognitive tests, such as the mini mental state exam. And so there's some very nice evidence showing that the degree of hearing impairment significantly impacts the outcome scores of the mini mental state exam. And this has really come to the fore during COVID when we've been trying to do online assessments, and we recognize that not only are we dealing with the lack of validity of many tests in the online setting, but the additional challenge of trying to manage cognitive scales with hearing impairment in the online context. So this is something that's certainly part of our day-to-day practice. And within a standard memory clinic, how common is hearing impairment? Now, these data come from a study a colleague of mine did in Manchester more than 20 years ago, looking at the prevalence of hearing impairment that was under-identified or unidentified in the memory clinic. And you can see that more than 80% of people had hearing impairment. Now, we repeated this a number of years later, and in fact, it hadn't changed. So we challenge you to do all the same within your clinical context or within the cohort of people you work with, and you'll find that these rates are extremely high. And there's a number of reasons for this, which I won't go into right now, but the point is, of course, that unidentified or unaddressed sensory impairment, both hearing and vision, impact on dementia significantly. First of all, there's evidence that there's more rapid cognitive decline and functional decline. Secondly, for people already with established dementia and behavioral disturbance, there's often an increase in behavioral disturbance if there's hearing and or vision impairment, particularly in contexts such as the care home setting, where there are a number of sensory challenges due to the environment. And of course, this can lead to increase in the use of antipsychotics and changes in care. It increases challenges with the communication barriers, leads to greater dependency, higher rates of caregiver burnout, reduced quality of life for both the person living with dementia and their care partner. And of course, there's emerging evidence of higher costs of care. So I think there's a very compelling case for addressing this issue of trying to understand the links between sensory impairment and cognitive impairment and dementia much more detailed. The other reason, of course, this has absolutely come to the fore in the past 2 or 3 years is because of the Lancet Commission, which many of you will be, or not all of you will be very familiar with. And of course, we know from the Lancet Commission that potentially Up to 40% of dementias are potentially reversible. And I say potentially because there's still some evidence about the modifiability still lacking. But if we address these 12 risk factors, and you'll all be very familiar with these, namely education, vascular risk factors, alcohol use, traumatic brain injury, late life depression, physical activity, smoking, air quality, social isolation, which accounts for an important part of the model of 3.5%. But actually what some people might not be quite aware of is that midlife hearing loss accounts for the largest proportion of this model. In other words, 8%. And the next highest, in fact, is at 5%, which is, I think, I'll probably get this wrong, but I think it's smoking. So it shows you the importance of this issue and why we need to address it, certainly from a prevention perspective. So what is the evidence linking hearing and cognitive impairment? Let me start by showing you some of the SenseCog data. And some of you will have seen these graphs before, but again, I think they tell an important story. So across multiple different large-scale epidemiological data sets, in other words, the English longitudinal study of aging, the American Health and Retirement Study, the PAN dataset, the PAN metadataset from SHARE across multiple European longitudinal studies of aging, we see that there is a decline in cognition with age, which is this black line, and it looks pretty similar across these three different graphs. Now, if you add in poor hearing function, that trajectory of decline is more rapid, and you can see that very similarly across these data sets involving multiple thousands of people. What about vision? Looks almost identical, doesn't it? In other words, that your expected trajectory of cognitive decline is exaggerated if you have vision impairment as well. So, is there an additive effect? And certainly our data show that there is. In other words, the blue line is where your cognitive trajectory would be if you had a single sensory deficit. But if you have dual sensory deficits, in other words, hearing and vision, you have an even more rapid decline. So these are important concepts to take on board. However, this refers only to the expected decline in cognition with aging. This doesn't necessarily address dementia. But if we look at global cognitive impairment and start addressing the question with regards to risk of dementia, we see the same kind of pattern using slightly different methodology. Again, if you've got hearing, your descent into dementia is faster. Likewise, vision, and again, both, that there's this additive effect of dual sensory impairment in terms of the impact on cognition and then also dementia. So, what are the kinds of cognitive impairment domains that are linked with hearing deficits? Well, the data have been emerging across multiple domains, certainly memory, but global cognition, if you've already seen, but executive dysfunction and processing speed. But there are a number of different challenges in looking at the research data around these, partly because there's this notion of peripheral versus central hearing impairment and the degree to which either of those takes control of this process or there's mixed. But also across the studies, there are variable definitions of hearing impairment. In other words, mild, moderate, severe, and profound, or continuous understanding of hearing impairment. And this makes it difficult to really tease these apart. But again, there's a growing literature, and you can see some references here on the bottom, some of them quite recent. And so it's quite an exciting field, and again, something that needs to be embraced. So one of the nice studies looking at the links between hearing loss and specifically the clinical syndrome of dementia is a meta-analysis done by my colleague David Loffrey at the Global Brain Health Institute, where I now work. And he looked at 36 studies of cognition and pure tone averages from audiometry. Now, why this is important is because these are objective measures of hearing impairment, because many of the large-scale longitudinal data sets look at hearing impairment based on self-report. And whereas that has some validity, there's higher validity if you look at objective measures, which these studies did. And lo and behold, we see significant associations between not only hearing loss and cognitive performance. Again, we know that. Hearing loss and cognitive impairment, like the graphs that I showed you, but also hearing loss and dementia. But again, looking back to the Lancet Commission, where this becomes important is because they did a very nice analysis looking at only longitudinal studies So whereas David's meta-analysis looked at cross-sectional studies, here with the Lancet Commission, they included only longitudinal studies of data with at least 5 years and adjusted for a number of covariates and came up with this key finding, that there's a 2 times greater risk of incident dementia amongst hearing impairment individuals over the age of 55 compared to non-hearing impaired individuals. So these are fairly powerful findings. So let me just turn my attention now to addressing the mechanisms linking hearing and cognitive impairment. And one of the very nice papers I can refer you to is this review by Tim Griffiths from 2020, in which the various psychological and biological pathways linking peripheral auditory function to cortical dementia-related changes were outlined very nicely. And I'll talk you through a couple of these. We can think about 3 hypothetical mechanisms regarding this link. One is the information degradation hypothesis. One is the sensory deprivation hypothesis, and the other is the common cause hypothesis, which probably has the strongest evidence. But again, it's likely that all 3 of these work together. So first of all, information degradation. And what we see here essentially is that there is a greater listening effort that's required because the information isn't going in and being perceived in the right way. So that cognitive processes have to be redirected to try to understand and interpret and decode what is being said because the peripheral input is impaired. And therefore this deprives one of using the cognitive experience and the cognitive effort in coding, for example. So what about the common cause hypothesis? So the common cause hypothesis, again, which probably has the most credence, is that there's some kind of common gremlin in the system, if you will, and that's driving hearing impairment, likely vision impairment as well, that's age-related, and cognitive impairment. Now, a very common aspect of this might be inflammatory processes, might be vascular pathology, and in other words, you're seeing this co-pathology that's being driven together. And why this is important to understand, of course, is because then in addressing the common pathway, you can address multiple outcomes, including hearing, vision, and cognition. And therefore, you're addressing this kind of crucible of comorbidity. And then the other hypothesis is sensory deprivation. So sensory deprivation essentially is about having impoverished sensory input because your eyes and your ears aren't working properly. And in this case, it actually leads to a disuse atrophy of key areas of the brain. In other words, cortical reallocation and deafferentational atrophy that are in areas that support speech perception and processing. So there's some very interesting work in this area. But some of the key questions that we need to answer are about the critical age, when this occurs, is that important? Also the duration of loss in terms of sensory loss that's required in order to result in this kind of cortical atrophy. And again, the degree of cortical reorganization that's required to impact on cognition still needs to be teased out. But in thinking about the sensory deprivation hypothesis, so I've just touched on really what we can consider the direct association, but there's also the indirect association. And this is because hearing impairment, as we know, results in decreased self-efficacy, can increase the risk of depression, can also lead to less physical activity, and also withdrawal from social activity. So that sounds very much like the types of risks that people face when they develop cognitive impairment. But again, taken alone, you can see that if you have hearing impairment related decrease in self-efficacy, increase in depression, decrease in physical activity, and decreased social activity, your risks of developing cognitive impairment are greater through this indirect route. So I'll just show you some work that we've done again from SenseCog in trying to tease out this direct versus this indirect kind of effect. And in this case, we've looked at the cascade model, which is looking at hearing, loneliness, social isolation, and cognitive impairment, and how all these factors link in. And this is extremely important in the current world that we're living because of the pandemic and how people experience very high rates of loneliness and social isolation, and you could say sensory deprivation as well, and the impact this has had on cognition. For those of us working in memory clinics or with people living with dementia or with MCI, I think most people have seen a huge drop-off in terms of the cognitive stage of their patients and the people they're working with through the pandemic. Again, for multiple reasons, but certainly some of this can be attributed to loneliness, social isolation, and one can argue loss of stimulation and hearing impairment. So what did we find? Well, first of all, in looking at the data, we found a direct relationship between hearing impairment and episodic memory. Now, I've already shown you those data. We also know that there's a direct impact of loneliness and memory, and social isolation and memory. But what we were also able to see through various models is that hearing impairment not only directly affects memory, but it also indirectly affects memory through the pathway of loneliness and through the pathway of social isolation. So you're kind of getting multiple hits. And I think why this is important is because if we go into this field thinking, easy, we'll fix hearing impairment with hearing aids, problem sorted, well, that's likely going to have limited success because of these multiple pathways. So we need to be thinking about, yes, addressing hearing impairment, for example, with hearing aids and hearing devices and supports, but also addressing the consequence of hearing impairment, such as social withdrawal, such as social isolation and loneliness and so on, in order to impact on the final outcome, which is cognitive function or quality of life. And there's some very interesting work that comes out of the basic biomedical sciences or the basic biological sciences, namely looking at sensory loss, social isolation, and cognitive impairment in songbirds. And essentially, what this work is very elegantly showing is that for songbirds, if they are socially isolated, they show decreased selectivity of auditory evoked activity in single cells. And so that isolation is actually affecting their ability to process sound and recognize song. So that is the biological basis for what potentially may be happening in humans. So lockdown in many ways was a bad thing from many perspectives. Of course, a necessary evil, but there was an evil aspect to it. Okay, so asking the question now, does sensory rehabilitation prevent dementia? So primary, secondary, and tertiary dementia. But this is an absolutely key question because everybody on the call will be aware that any intervention that delays dementia onset by 5 years can lead to a nearly 60% reduction in prevalence of dementia with significantly lower costs. So this is kind of, the holy grail of dementia work at the moment. So primary prevention is reducing risk factors before the disease process begins. And so if we can look at hearing impairment from a primary prevention perspective, then that would be extremely powerful. But of course, there are some challenges with the evidence, and we're not entirely there. So whereas we can see that there's a very high risk based on the work done by the Lancet Commission and others, what we really need to get is the prospective evidence that cognitively intact individuals who are followed longitudinally will decrease or not decrease according to whether their hearing impairment is corrected or not. So let me just go through here. So let me share with you these data here. Again, this is from SenseCog, and here it doesn't quite address the question because again, it comes from the epidemiological data, but it starts to give us a better sense of whether we're heading around in this direction of primary prevention. And what this is here is looking at, again, the trajectory of cognitive decline, specifically in memory, before and after using a hearing aid. And so this was a way in which it's called a spline model, in which the data were looked at, and what's called a knot was put in the data. A knot is over here. In other words, everybody was corrected to the point where they received a hearing aid. And then we looked at the cognitive decline after. And we can see that there's a difference before and after the hearing aid, suggesting that this device may be doing something and giving some suggestion that there may be a primary prevention element in place. Now, I'll just go back to the slide, actually, because one of the challenges, of course, in looking at data where a hearing aid is supplied is that it doesn't answer the question as to whether a person used the hearing aid. All we know from these data is that the hearing aid was supplied. And of course, the adherence rates with hearing aids are very poor, particularly as people develop cognitive impairment as they get older. So this question can be also addressed in the vision context. Now, I don't have the slide here, but a very similar picture and a very similar outcome has been demonstrated from our data with cataract surgery. So again, the cognitive decline before cataract surgery, the cataract surgery, and after, and we see again a decrease or attenuation in the decline. And why that's important, of course, is because cataract surgery cannot be reversed. So unlike a hearing aid, you don't know how much that aid has been used. With a cataract, you have very solid evidence that this is an intervention that is enduring. Okay, so moving on with secondary prevention. So in secondary prevention, here we're looking at early detection and prevention of the disease through screening and intervention in those at risk of or already with MCI. So it's a slightly different question, further along the trajectory, if you will. And in terms of hearing impairment as a biomarker of the early stage of AD, I mean, this work goes back already 30 years to the 1990s, when there was some very interesting work already describing Alzheimer's disease pathology in key areas that were linked with cortical and linked with cognitive impairment that were important in Alzheimer's disease. However, one of the challenges in terms of hearing impairment as a biomarker is that AD pathology tends to occur quite late in the Braak stage, in the auditory association cortices. And therefore, if we're thinking that it might be a biomarker that leads to secondary prevention, it's a little bit challenging. So we've been looking at other elements to see whether there's a hearing biomarker in the way that there is quite a growing evidence of a retinal biomarker and eye biomarkers to indicate the onset of Alzheimer's disease. And one of these biomarkers, basically addressing hidden hearing, is called a dichotic sentence identification test. And this seems to be the most sensitive test to pick up memory impairment amongst people with MCI. Now, it's quite a challenging test, and essentially you get a nonsensical sentence delivered to the right ear and the left ear at the same time, and you've got to tease these apart. So it takes quite a degree of cognitive ability to do that. And again, this is trying to tease out whether somebody's at risk of MCI through their hearing impairment. So moving away from the screening element of secondary prevention, let's say a few words about the intervention element. So when thinking about interventions for those at risk or of dementia or those with MCI, we can think about hearing aid rehabilitation, cochlear implants, and communication strategies. So some of the most important evidence that hopefully we'll be seeing very soon this year will be from the ACHIEVE study led by Frank Lynn's group, and there's also work in the UK being done in this area as well. And this is looking at people already with MCI getting hearing aids versus not getting hearing aids. And this is still an ongoing study because it's a very long, difficult study to do prospectively, but this will really address this question, we hope, of whether supplying hearing aids for people with hearing impairment in the very early stages of Alzheimer's disease or MCI will make a difference in terms of their trajectory of decline into a full dementia syndrome. What we know from the pilot study already is that this kind of approach improves hearing handicap, but of course the pilot study was not powered to detect cognitive or functional changes. And we wait for the larger study, which we'll be reporting this year in over 900 people. So the next question is tertiary prevention. So this is the area that I'm most comfortable and spend most of my time working in. And tertiary prevention is the slowing decline or improving outcomes in people already with dementia. And when we started the SenseCog program a few years ago, we started looking at what the evidence was, and we found a number of studies of both hearing and vision interventions for people already with dementia. But unfortunately, most of them were low to moderate quality. There was only one high quality RCT of a specific hearing aid intervention identified. So this told us that we had our work cut out, and we needed to design a properly powered, properly developed RCT to try to address this question of whether hearing and vision rehabilitation improves outcomes in people already with dementia. And the types of sensory interventions that we looked at included hearing aids, assisted listening devices, communication strategies, and so on. And in terms of vision, prism lenses, rehabilitation training, and cataract surgery. So we looked at a range of different interventions, and we also scoped support care needs of people with hearing and vision impairment across Europe to get a cross-national perspective to try to develop an intervention that would be suitable for testing. And this was what we called the sensory support intervention. So after about 24 months of intervention modeling work and scoping, we undertook a field trial of this intervention. in 19 dyads. A dyad is a person with dementia and their care partner across multiple countries, to try to see whether this would be a feasible and acceptable approach. So first of all, we had to screen people with dementia. We generally included people with a MoCA score of equal to or greater than 10, with a diagnosis of dementia of either AD, vascular, or mixed dementia. And we purposely looked at the most common causes of dementia. And we screened them for a certain degree of hearing impairment and or vision impairment, having a care partner, and living at home. And what was the intervention that we developed? Well, the first element of the intervention was ensuring that everybody had a full hearing and vision assessment. Now, that doesn't sound like a particularly novel intervention. However, based on our previous data, which I started the talk with, we know that the vast majority of people living with dementia have not had correct hearing assessments, and very often have outdated vision assessments. Vision is certainly much better looked after than hearing, but this is something that we could not take for granted, so it was developed into the intervention. So people who screened positive got a full hearing and vision assessment. They were then given corrective devices, glasses, hearing aids, or pocket talkers. And then a crucial element was this, what we call adherence support. So we had a sensory support therapist who worked with the person with dementia and their care partner to support adherence. And that was particularly important for hearing aids, because of course, the adherence rates with people with dementia is extremely low. They find them difficult to tolerate. They find it difficult to use and interpret. They also have difficulties with manipulating the tiny hearing aids, and even basic elements such as maintenance and battery changing. We also worked on communication training and, importantly, social networking. Again, coming back to my slide and my discussion about the songbirds, there are direct and indirect pathways impacting on cognition. And we need to think about all these pathways in a multimodal complex intervention. So this goes far beyond simply providing a hearing aid and glasses to a person with dementia. It's looking at a package of sensory health. And I'll just briefly tell you what we found from our feasibility study. Well, first of all, even though it was not powered to look at this, we were able to get a signal of improved quality of life, which seemed to be clinically significant. We saw improvements in behavioral disturbance. We also saw improvement in self-efficacy and relationship satisfaction, and some improvements in care burden. So this was enough to tell us that we were probably on the right track, and we could go ahead for a full-scale RCT, which indeed we did. And some of the qualitative findings from 10 of the dyads supported those findings. I won't go through them in detail, but essentially we had some very nice reports of improved functional ability, acceptability of the intervention. People were very happy to work with a sensory therapist to look at adherence, increased knowledge and awareness, improved socialization, and other key outcomes. So this leads me to the SenseCog RCT, where we are now. So this is a large-scale definitive trial looking at the impact of this complex intervention on quality of life at 18 and 36 weeks, and looking at a range of secondary outcomes such as function, cognition, behavior, and caregiver outcomes as well. And we've been conducting this trial across multiple sites in Europe. And where we are now, I'm very pleased to say that in spite of the lockdown, in spite of what we had to manage, and all clinical trials have suffered during the pandemic, we've been able to now complete our last patient, our last participant, last visit a few weeks ago, and we are now just in the process of looking at the data and data lock so that we can analyze this and report the outcomes in June. But a few things to say, first of all, is that we had over 70% of people completing the primary endpoint, which was quite positive for a trial involving people with dementia and comorbidity. We had no serious adverse effects that were related to the intervention, suggesting, again, this is a fairly straightforward, potentially feasible and acceptable intervention. And we had very high adherence rates to the devices, which is extremely important, of course, because this is a key element in sensory cognitive health in people with dementia, is about adherence and supporting the ongoing use of devices to support sensory health. Now, I'm just going to check with Naj how we're doing with time.
couple of minutes, and then because there are a couple of questions.
Okay.
It'd be nice if, yeah.
Okay, let me just finish a couple of things. So in summary, I've talked about primary, secondary, and tertiary prevention with regards to sensory cognitive health. And then the final piece, I just wanted to let people be aware that we are now working in long-term care settings addressing sensory cognitive health, taking that SenseCog intervention from the RCT and adapting it to long-term care settings. Now, this is a fairly complex process because, sorry, let me just back up a minute here. What we found from previous work was that the understanding of knowledge, awareness, and practice of sensory cognitive health in long-term care settings was fairly poor. So whereas there was a reasonably high awareness of the importance of hearing and vision in people living with dementia, people's confidence and ability to address these issues was quite low. And there was a real gap in terms of training and understanding of how to go about this, particularly when it came to things like managing hearing aids, devices, ensuring that people are adherent and they're not getting lost or getting tied up with the rubbish and the changing of the sheets and so on. So a lot of work had to be done. And again, we've just come out with a systematic narrative review looking at 16 studies of the effectiveness of hearing rehabilitation in care home residents. And what we found is
we were doing so well. Hopefully, Professor Leroi can rejoin.
with their screening and their needs for rehabilitation, but you also need to then look at the care staff and their level of awareness, their level of training. You then need to be thinking about the environmental level, because many care homes can be very sensorially and challenging places rather than sensory friendly environments with noise, either for people with hyperacusis or volumes of televisions, for example. Smells and sounds that can be quite difficult, poor lighting, too much lighting, and so on. So all of these things need to be addressed if you're serious about doing a holistic, multifaceted approach to address sensory cognitive health in the care home settings. And so we're now going through a process of workshops to adapt our intervention into this model so that we can then feasibility test it in a number of care homes in a small cluster randomized pilot trial. And if we get a positive outcome that it's feasible and possible to do, we will take that forward into a definitive trial to ensure that this very important area of healthcare for people living with dementia is addressed. And I think I'm going to leave it there. Thank you very much for your attention.